Hi, everyone. This is Rebecca from CHAMPS. I just want to welcome everyone to our webinar where Dr. Lori Feldman-Winter will be presenting. I just want to give you guys a quick reminder to mute your line when you're not speaking, which is by pressing *6. You can unmute by pressing #6 if you have a question. Also, please do not put your line on hold, otherwise the music will be broadcast to the webinar audio. And just one last thing, we just wanted to ask if you could, if you're signed in online, to enter the name of your hospital or your organization in the chat box. You can send it to the Breastfeeding Center. We're just interested to see where people are listening from. So if the chat box should be up at the top right, it looks like a speech bubble. That would be great. Okay, I think that's everything. We'll pass it on to Dr. Feldman-Winter, and she can get started.
Welcome, everyone. Good morning or good afternoon, depending on where you're calling in from. And welcome to the Wednesday webinar series from CHAMPS. I will be your presenter and host for the next hour. As mentioned, my name is Lori Feldman-Winter. I'm a pediatrician from Cooper University Hospital in Camden, New Jersey. And I serve as the physician lead on the CHAMPS project, Communities and Hospitals Advancing Maternity Practices, a project that's generously funded by the W.K. Kellogg Foundation. And this webinar has additional support from the Mississippi Department of Health, Blue Cross and Blue Shield of Mississippi, and ROSE, reaching our sisters everywhere. So thanks to everyone for their support. I'm delighted to be the presenter today and to bring you a webinar that's focused on a heated debate that has ensued over the past 6 months as a result of several inflammatory opinion papers that were published in renowned journals such as the JAMA network journals. And before I get started, I just wanted to explain the slide template for today. So as one who has worked in the field of breastfeeding, including work related to implementation of the Baby-Friendly Hospital Initiative in the United States and even around the globe, these publications have launched an all-out attack on this initiative. So with the firestorm of attacks, I thought it would be appropriate to fight fire with fire. And thus, the image of the slide template is a flame. This illustration is really of my burning desire to get this right. I want to clarify what's been very misleading in the literature, and hopefully all of you will take away from the talk today the evidence and the confidence to continue pursuing safe implementation of the 10 steps, and will continue to pursue the baby-friendly designation process, as well as sustain your efforts to improve the environment of care for mothers, newborns, and their families throughout the United States. And I hope to leave time at the end of this talk today for questions and comments. So please feel free to enter any of these in the chat box, and I'll be getting back to questions after my slides. And I hope also to really continue this conversation even after today, because I think the more we continue to discuss these issues, the better we'll understand and even reveal the best evidence. So I have no disclosures that are commercial or financial or otherwise related to this talk this afternoon. My learning objectives for today are to explain the difference between a published opinion versus a published and peer-reviewed research study. Then I'm going to present the 2 papers in question. Both of these opinion pieces attack the Baby-Friendly Hospital Initiative on the premise of its efficacy in support of breastfeeding, meaning that all these transformational changes to achieve baby-friendly designation may not be worth it if it doesn't do what it's intended to do, which is to increase breastfeeding initiation and duration. The articles also attack the Baby-Friendly Hospital Initiative on the premise that there is more risk in implementing specific steps than there is benefit. And I intend to present their arguments and counter each one of them with the evidence that supports the safety of implementing the 10 steps. And I'm going to end with the evidence that the Baby Friendly Hospital Initiative is worth it and it does work. So these are the two papers in question. And you can see the blue box here. This is the article that was published by Joel Bass and colleagues, and it's published as a viewpoint in JAMA Pediatrics. And JAMA Pediatrics is part of the JAMA network. This was an unsolicited commentary, really, about the Baby Friendly Hospital Initiative. And curiously, members of the section on breastfeeding from the American Academy of Pediatrics published a counter viewpoint in the same volume of this journal. And that paper was published by Joan Meek and Larry Noble. But that paper, unfortunately, received much less attention than this paper that was published by Joel Bass and colleagues. In red, in this red rectangle, you can see the editorial that was published by Valerie Flowerman and her colleague in JAMA. That's the main journal of the JAMA network. And this was actually a solicited companion piece to the United States Preventive Services Task Force updated recommendations for interventions to support breastfeeding. And I'm going to come back and explain what all that means in a little bit. Again, published in the same volume. So the U.S. Preventive Services Task Force recommendations were published in the same volume as the Flowerman invited editorial. Again, looking at systematic interventions to support breastfeeding, namely the Baby Friendly Hospital Initiative. So first, opinions are not studies. They are peer-reviewed, but really to a point. There's no real statistics, there's no research methods to review, and there's very little focus on the ethics of that position or of whatever the author has taken. And it really can be submitted by anybody. It is true that very often these editorial pieces are published by well-known authors, but sometimes not so well-known authors are able to publish viewpoints or editorials because of the topic, because they're so inflammatory that, in fact, they draw readership and attention to the journal. So, in fact, opinion pieces are often controversial because that's great for the journal because people want to read them. So more people will want to download these articles and circulate them, and the journal will certainly gain notoriety. The media tends to pick up on the controversial opinion pieces as well because the media benefits by reporting what's been reported in these editorial pieces, and that becomes also very popular because people are interested in hearing about all this controversy. Unfortunately, the media often erroneously picks up on these opinion pieces as a, quote, new study. And that's the unfortunate thing because I think in that case the public is definitely misled. These opinions don't really publish any new data. This isn't a research study. And so by the media picking up on it as a new study, it's really just a new opinion. Then folks are led to believe that there's some new evidence that would be potentially damning for whatever it is that they're about. The good news is that there's been a backlash to this firestorm, and there have been numerous letters to the editor published in JAMA Pediatrics in response to the Joel Bass viewpoint, and many more are pouring in. So some that have already been published were actually in print as of January 30th, just several weeks ago, and they're available on the CHAMP's website for anyone to read. I've bulleted some of the important points here from some of these letters to the editor, but many of these points I'm going to come back to. in the conversation over the next hour. So for today, what I will not focus on is the author's conflict of interest, the formula company sponsorship that may have skewed their opinions, their non-disclosure. I could maybe spend an hour just talking about that. But rather, what I will focus on is the content of their arguments and where I believe those arguments fall short. And I'll present the evidence base for the support of exclusive breastfeeding and also discuss safe implementation of the Baby-Friendly Hospital Initiative. So in summary of the Bass viewpoint, his key topic is around implementation of the Baby-Friendly Hospital Initiative, and in particular how that relates to something that is honestly very tragic, and that is this event, or what we call sudden unexpected postnatal collapse, or SUPC, that can occur in the first couple of days of life. And so his assertion is that the 10 steps is rigid, and that by applying this rigid methodology in the objective of achieving baby-friendly designation, that is somehow linked to SUPC. He also implies that any one of the steps can be hazardous, things such as rooming in or skin-to-skin, and even avoidance of infant formula can be in and of itself hazardous to a baby, and goes on, and I will, again, illustrate his points there. And finally, in his attack on the Baby-Friendly Hospital Initiative in general, he disagrees with the Surgeon General's call to action, which said that as a country, we should actually be accelerating the implementation of the Baby-Friendly Hospital Initiative. And instead, he believes that there's sufficient evidence to actually retract this recommendation, and that we should be dialing back our support and even funding that's been put forth to try to create more baby-friendly designated hospitals in the U.S. So going back, this is, again, the cover page of the Joel Bass viewpoint. If we just focus on the title itself, unintended consequences of current breastfeeding initiatives. So really what he's saying is that the current breastfeeding initiatives are causal in these unintended consequences. And what are the unintended consequences that he's talking about? Primarily, it's this issue of sudden unexpected postnatal collapse. And in fact, there's no evidence to support the assertion that, in fact, the breastfeeding initiatives or the Baby-Friendly Hospital Initiative is causal in any way to SUPC or sudden unexpected postnatal collapse. So there's no evidence that it's related, that one actually causes the other. And furthermore, there's no evidence that these events are even changing with the increase in baby-friendly hospitals. So what is SUPC? Let's just look at the definition and try to understand what these events are. Well, similar to SIDS, or sudden infant death syndrome, or SUIDS, unexpected infant death, which are deaths that occur in babies within the first year of life. SUPC is a very unique category of potential deaths, not always death. Sometimes it's just collapse, and sometimes there's morbidity, or sometimes these babies recover completely. But these are events that really occur within the first week of life. And it occurs in a previously healthy baby, again, similar to SIDS, normal APGARs, not premature. And the incidence is kind of all over the map, and it really speaks to the fact that there's just so little evidence to really understand what's going on here. And the focus on this issue, SUPC, has really increased over the past 5 to 10 years. In these two different reports that I've highlighted on this slide, you can see that just the definition of and epidemiology of when this is happening is very different. In Herlenius's report, he said that about a third happened within the first 2 hours, and in Bescher's report, he said that up to 3/4 are occurring in the first couple hours of life. The point is that most of these events do happen within the first day, and so the focus is truly on the delivery hospital experience. So is SUPC increasing because of the BFHI? Well, there's no evidence to support that contention. In fact, in Dass's viewpoint, he reports data from the Massachusetts Vital Statistics that implied that SUPC is on the rise, and he suggests that that's because of the increase in BFHI and baby-friendly hospitals. But in fact, there's no evidence in what he presents to say that one is directly related to the other. And in fact, there's been somewhat of a plateau of baby-friendly designated hospitals in Massachusetts. So he does report that the proportion of deaths occurring within the first month of life, there's sort of two categories of deaths that can occur within the infant's first year of life. Those that occur within the first month are neonatal deaths, or those that occur after 1 month, so from 1 month to 1 year of age, and those are what we define as post-neonatal deaths. And he does report that the proportion of deaths that are occurring within the first month of life, first 28 days of life, has increased. And that's really because the denominator, all SIDS cases, are fortunately going down, and that's because of many of the initiatives to implement the safe sleep practices. So when the denominator, all cases of SIDS, go down, it really looks like the total number of cases that are occurring in the first month of life are going up, but it's really a proportion of the deaths are going up. And it's because we don't really understand, and it may be a completely separate cause that's leading to these deaths, particularly those happening in the first couple of days of life. In one of the letters to the editor by Lorraine Boyd that was published in January, she did a similar review in New York City where they've had a very active collaborative working on implementation of the Baby-Friendly Hospital Initiative, and they found that there were no increased SIDS deaths or SUPC deaths between birth and 1 month that occurred during the period of a dramatic increase in the number of baby-friendly hospitals, and that's between 2012 and 2014. So again, there's just really no evidence to support the contention that there is this link between the Baby-Friendly Hospital Initiative and these events that are horrific, but we really still don't understand exactly what causes them. I think there are theories, and we tried to address some of those theories in what I'll present to you in our clinical report from the AAP, but we really don't know. Bass goes on to say that full compliance of the 10 steps, meaning implementing all the 10 steps, might in fact inadvertently be promoting hazardous practices and might in fact have counterproductive outcomes. And this is simply not true. It's not really the full compliance that compromises safety. It's really the poor compliance. And I know that there has been a terrific amount of excitement in how many hospitals are working towards baby-friendly designation. It's exciting because, in fact, all these great practices are, in fact, resulting in improved care and more breastfeeding and better patient satisfaction. People really do like the changes. It's just more family-friendly. But it's not because of full compliance. It's really because of some of the efforts to implement the Baby-Friendly Hospital Initiative is sort of marginal compliance. And again, the evidence that I'll go through supporting every one of the 10 steps underpinning the Baby-Friendly Hospital Initiative is that produces optimal outcomes as opposed to events such as SUPC. There's no evidence of that linkage. So what is the evidence first for skin-to-skin care? The Cochrane database system has published an extensive review of the literature. There's been even additional literature that's come out even since this Cochrane database review, that the importance of skin-to-skin care really can't be overstated. The mother's body is truly the natural environment for that baby's transition, for the mother's transition as well. It's crucial for physiologic stabilization of the baby with regulating heart rate and respiratory rate, temperature. It also decreases stress in both mother and baby, providing analgesia and decreased cortisol levels, and ultimately it facilitates early establishment of breastfeeding. In fact, babies that attach during that first hour of skin-to-skin actually do much better breastfeeding long-term, and I'll show you some more evidence for that as we move along. But it should be done safely in a way that wouldn't lead to suffocation or strangulation or anything that would close off the baby's airway. We know babies are primarily nose breathers, so anything that would crush the baby's nasal passage would make that skin-to-skin position, whether the baby's skin-to-skin or anywhere else for that matter, would make that baby's position precarious. And so in our clinical report, we enumerated some of the recommendations for safe positioning of skin-to-skin, basically things that allow for that baby's airway to remain open. And the thing that I circled here is really something that I think in a good way we're really paying a lot more attention to, and that is continuous monitoring. It is important because of these events occurring most often within the first couple of hours of life, that the mother baby right after delivery be continuously monitored. So we no longer say something, to the extent of, we'll just place the baby skin to skin and then leave them alone. We don't really mean leave them alone. We really mean to not only monitor, but this is the opportune time to assist and support with breastfeeding, which is another one of the parts of step 4 from the 10 steps. Bass goes on to say that this is a period of time when babies are skin-to-skin that direct continuous observation is not likely to occur. And I have to say that maybe that's true in his hospital. Maybe they are trying to do skin-to-skin care and they're not doing continuous monitoring. And just to be honest, that this is problematic. Many hospitals that are working on implementation of the 10 steps have to really think about their processes in ways that support safety. And so while the AAP clinical report recommends continuous observation, how much every hospital is actually doing to support continuous observation, I would say is very variable. Going hospital to hospital, it may be a staffing issue, but even beyond a staffing issue, it may just be about different processes and where staff are assigned. Certainly if the hospital hasn't moved towards rooming in, then there's staff that's stuck monitoring babies in a large newborn nursery. And so it's really all about restructuring the entire delivery care environment. And then Bass goes on to further contend that the Baby-Friendly Hospital Initiative will inadvertently result in potentially exhausted or sedated postpartum mothers and somehow persuade her to feed her infant even when she's not physically able to do so, and that this may result in prone positioning or co-sleeping, meaning bed sharing, in direct contrast to the safe sleep recommendations, and also babies could be falling out of bed if moms are falling asleep with their babies skin to skin. So all of these contentions about the Baby-Friendly Hospital Initiative really is saying that it's the 10 steps that would lead to these situations, but really the 10 steps don't lead to these conditions if the 10 steps are done in a safe and systematic and organized fashion. In fact, good nursing care supports moms to feed babies safely and do so in a way that would prevent a mother who's exhausted or too sedated to be able to hold her baby or feed her baby independently. In addition, we recommend safe sleep positioning, meaning supine position on a separate sleep surface, avoiding bed sharing. So whether the mom and baby are in the hospital or at home, the baby should not be sharing the same sleep surface, but be sharing the same sleep room. So babies should be in the same room. We recommend room sharing actually as one of the recommendations for SIDS prevention. We, from the AAP, had just reiterated that and have written letters back to some of the letters to the editor about the importance of maintaining rooming in and sharing that room space to promote SIDS prevention. So the evidence for rooming in, or step 7, again, is not only to model the behavior that we want to continue to exist after moms and babies go home as a method of SIDS prevention, but it's also consistent with contemporary models of family-centered care, meaning that we do better when we care for the mother, baby, family, really the whole team is together as we're providing our exams for the mom and the baby. We can provide optimal anticipatory guidance when the baby's there. With rooming in, mothers actually learn skills in caring for their newborns. And ultimately, rooming in leads to patient satisfaction. Mothers really do want to be with their babies. They just don't want to be the complete care provider for their babies. And so, you know, we still are providing the same level of care for the babies, and we're providing the same level of care for the mothers. I like to think of it as sort of a rooming in and shared or semi-private room. Who would you rather have a semi-private room with but your own baby? And so the nursing care, the level of attention that's paid to both mom and baby really shouldn't be changed just because you now have a mother-infant unit. And there are many new devices that are being invented. So innovation has definitely spawned out of this desire for improved care from rooming in. These are different kinds of bassinets that facilitate the separate sleep space or separate sleep surface, such as in the bassinet, but within arm's reach. So these kinds of bassinets facilitate care and continued breastfeeding, and even moms bring the babies into bed for skin-to-skin care and continued breastfeeding. But then when moms are sleepy and want to go to sleep, they can place their babies on that separate sleep surface. And these devices are actually being studied in a randomized controlled trial at University of North Carolina by Kristen Tully and her group. So we're excited about that research. Bass goes on to say that in terms of exclusive breastfeeding, that in fact there's no exceptions, no allowable exceptions for non-exclusive breastfeeding, supplementing with formula, and that's just not true. There are definitely contraindications to breastfeed for the baby, classic form of galactosemia, but then there's also medical indications for supplementation, and every hospital needs to work out what their committee agrees upon to be the medical indications. These should be written up in policies and then implemented. I suspect that what Bess may have been referring to is the recommendation that came out in May of 2015 from the Joint Commission. So the Joint Commission actually has a core measure on exclusive breastfeeding, and the core measure is PCO5, or Perinatal Care Core Measure, number 5. And that core measure was modified slightly in May of 2015 to say that maternal medical conditions are no longer excluded. And this change was made because these conditions are, first of all, unusual. It only affects about 2% of patients, and they're very difficult to monitor and capture electronically using the electronic health record. So it's really, I think, a matter of PCO5 understanding and PCO5 measuring exclusive breastfeeding with the goal that you're not going to ever reach 100%, and nor does the Baby-Friendly Hospital Initiative expect that 100% of breastfeeding babies are going to be exclusively breastfeeding. The margin between exclusivity and those that require supplementation should be around 10%, but even this might change to some degree depending on the level of acuity that the hospital serves. So really the expectation is that not that there's no exceptions, that's just not the case. There certainly are medical indications for supplementation, and they can be derived from the newborn, but they can also be derived from the mother. And in many cases, they're temporary. And so as long as that is addressed and documented, then that is not at all counter to Step 6 from the Baby-Friendly Hospital Initiative. So as I mentioned, Step 6 is all about the avoidance of unnecessary infant formula, so formula that's not medically indicated. And in order to do that, I think it's really important that the staff and providers taking care of the mother and baby understand normal physiology and really define these medical indications and put that in policy and practice. And then what your actual order set looks like, who's allowed to do the ordering, you know, is this a physician order, a nursing order, and really revise those protocols accordingly. So Beth goes on to say that when the justification for breastfeeding exclusivity was made in the 10 steps, it was done with known evidence that if supplementation was given for a medical indication, there was actually no adverse effect on the duration of breastfeeding. And that's not the point. The justification for exclusive breastfeeding is really all about the fact that most babies and mothers can, in fact, exclusively breastfeed. That exclusive breastfeeding really does support the best establishment and duration of breastfeeding, but primarily that the justification for exclusive breastfeeding is that the health outcomes related to breastfeeding are dose-dependent, meaning that the more exclusive the baby's diet, the more benefit in terms of health outcomes that baby will reap. So any supplementation is going to undermine the baby's protection from things such as otitis media or diarrhea or any other health effects that are related to not breastfeeding. And so I've just summarized all of this. There's evidence for every one of the things that I've summarized. For the mother, supplementation will decrease her confidence, self-efficacy, really interferes with the entire apparatus that supports the establishment of breastfeeding. The baby, the risks of supplementation are really too long of a list to go through, but really think about the microscopic changes that occurs to the baby's gut, and that's really where it all gets started, so that any little bit of supplementation will affect the immunobiology, which then has a cascade of events that protect the baby. And then the diet. It just interferes with the baby's ability to suckle and even the hormonal stimulation that supports continued breastfeeding. And it really affects the family. So if a baby is supplemented, even early on, then that baby's going to be more likely to get sick, and sick babies affect the whole family. Let's face it, moms need to take off from work, or fathers need to take care of a sick baby, or a support system needs to pitch in if babies are going to be suffering from illness because of non-exclusive breastfeeding. Another quote from the BASS viewpoint is related to this, quote, ban on pacifiers. And so step 9, the fact that babies shouldn't be exposed to artificial nipples or pacifiers. And he really relates the evidence that pacifiers protect against SIDS as the reason to support early introduction of pacifier use to begin to do this. And he kind of models this whole picture by talking about SIDS protection from pacifier use and then SUPC events occurring in the first week of life. Well, that's problematic because there's really no evidence that pacifiers reduce the risk of SUPC. And as I mentioned, SUPC is a distinct disease different from SUIDs or SIDS. And so we don't have to worry that not introducing pacifiers is going to somehow increase the likelihood that babies will have these events, such as SUPC. And there's plenty of time for babies to have pacifiers introduced as a method to protect against SIDS. And really the AAP, both the section on breastfeeding and the task force on SIDS agree that pacifiers can be introduced after breastfeeding is established. So coincidentally, or maybe not so much, really the same day that the BASS viewpoint was published online, which was in August of 2016, the AAP published online Safe Sleep and Skin-to-Skin Care for the Neonatal Period. And this is a clinical report. So just a little background about what a clinical report is from the AAP versus what a policy statement is. So a clinical report from the American Academy of Pediatrics provides guidance for the clinician in rendering pediatric care. So it's really meant for clinical practice, for clinicians. It doesn't really have the same level of evidence to create a policy. So the guidance specifically does not say we recommend 1, 2, 3, 4. Instead, these clinical reports, and more clinical reports are being published because, we really don't have the level of evidence to actually be able to come out with as many policies as we do clinical reports. So at the end, we list suggestions and conclusions. So there's a list of the evidence that we do have and suggestions for clinical practice. A policy statement from the American Academy of Pediatrics, on the other hand, is a paper that describes organizational principles to guide and define the child health care system and or to improve the health of all children. And it typically ends with a list of recommendations. So we, the AAP, specifically recommend that you do X, Y, Z. And so it's just a little different, and I think it really speaks to the fact that we're really still young in this process of evaluating the evidence to best support the 10 steps. We have some evidence and we have some concerns related to SUPC and other things that happen in the delivery period, but we still need a body of evidence in order to actually create an evidence-based policy. So the AAP summary, and I say here recommendations, but really suggestions, are that skin-to-skin practices should be standardized in hospitals, and I said we do definitely have room for improvement there, and that there be a standardized sequence of events after delivery, and I'm going to talk more about this next month in terms of how to get there, how to actually use quality improvement to get to this standardized delivery event that supports immediate skin-to-skin contact. Documentation, direct observation, positioning, as I mentioned, to avoid airway obstruction, frequent assessments, really assessing the mother's level of fatigue so we don't get into that situation that BASS talks about, avoiding bed sharing as the AAP recommends, and then promoting supine sleep to reduce the chance of SIDS or SUIDs, and finally training, which I think is important for any kind of quality improvement initiative. So turning our focus now to the Flowerman editorial. Again, this was the companion piece to the U.S. Preventive Services Task Force. Feldman really exaggerates the fact that this U.S. Preventive Services Task Force said that there really wasn't great evidence to support systematic intervention to support breastfeeding. What they mean by that, systematic intervention to support breastfeeding, basically what they mean is the Baby Friendly Hospital Initiative, which is a systematic intervention that is intended to support breastfeeding. And so she really directly attacks the BFHI to say, hey, there's no evidence to support continuation of BFHI because the evidence isn't there, and that's what the U.S. Preventive Services Task Force said. And in fact, she goes on to say that the harms of these interventions actually may outweigh the benefits. And again, she goes back to this issue of exclusive breastfeeding as being problematic, and she actually recommends against exclusive breastfeeding, and we'll talk a little bit about that. So first, to back up, what is the USPSTF, United States Preventive Services Task Force? What it is a panel of experts. They're generally primary care docs, as well as statisticians or epidemiologists, researchers, that come together and provide a list of recommendations for clinical preventive services, so what primary care docs should be doing every day in their practice. So this group that comes together is supported by a very small agency that sits under the umbrella of our government Department of Health and Human Services. So AHRQ, or Agency for Healthcare Research and Quality, is one of those arms. It's the smallest arm of HHS. And they spend most of their time doing these evidence-based reviews to say, this is what the evidence is, and this is what you ought to be doing. And they have very strict criteria for the kinds of studies that are included in their reviews, and they're very conservative with the recommendations that they make. And one of the things I should say is that they don't consider costs. So they don't do cost analyses in any of their recommendations. So this is the paper that was published in JAMA in the same edition as the Flowerman editorial about primary care interventions. And the purpose was to update what had already been published in 2008. So they do these reviews of the evidence every 10 years or so. And the recommendation remained that there was B-level evidence, which is pretty good, to say that there's a bunch of different primary care interventions that you should be doing as primary care clinicians to support breastfeeding. And they go on and talk about each of those. But really what they focus on are the individual interventions. When they look at these systematic interventions, they just didn't find that much evidence. At least they didn't find that much evidence that they were willing to include in their review. They only really found 2 studies that addressed the BFHI, and they were pre-post studies, so observational studies before and after. And only one of them, I mean, it was really the same author, and the first study was really focused on just hospitals in Maine, and then the second study was expanding beyond Maine and looking at hospitals that took up a sizable portion of the United States. So really just that one study that was observational pre-post, Baby Friendly Hospital Initiative designation, did in fact find that there was a statistically significant higher rate of breastfeeding initiation and exclusive breastfeeding at 4 weeks in women with lower education. So they didn't find it for all women, but they found it for women with lower education. So the problems with this analysis, there are many. First of all, they excluded the one and only randomized controlled trial that's ever been done on the BFHI, and that was the PROBIT study from Belarus that we've all used for many years. That was published by Kramer in Canada and have looked at health outcomes related to that study. But because it was done in Belarus and a while ago, so they sort of said in their explanation as to why it was excluded is that it was done so long ago that Belarus these days, can't be applied to the U.S. for whatever reason. So that was excluded, and then, as I mentioned, just really the Hawkins studies, both Maine only and then the one that was a little bit larger, were included. They excluded a lot of non-randomized controlled trials that were pre-post studies. They excluded all the studies from Boston Medical Center. That was really the first inner-city hospital to implement the BFHI with excellent results on breastfeeding initiation and duration. They excluded our study looking at education, which was systematic. We intervened in multiple residency programs in the United States and had a control. We actually had control hospitals. So they excluded a lot of studies that they said were controlled before and after kind of studies or observational studies, but then they included the Hawkins studies. So I'm kind of confused. I'm not sure exactly why they included and excluded certain studies, but there's definitely problems with what was included and the fact that there was not sufficient kinds of studies that they typically include in their type of review. So really the takeaways from what the U.S. Preventive Services Task Force said is that, well, there's some evidence that actually the BFHI works in women with low education, so why not continue to recommend it? I think it's a missed opportunity to say that system-level support doesn't work. And really, they didn't look at every one of the 10 steps to say that there's a body of evidence underpinning really many of the different steps, like step 4 or step 6 or rooming in, to look at the evidence on outcomes. And again, there's issues with excluding the PROBIT study. Maybe, who knows, maybe this is the future to do a real, true randomized control trial or cluster randomization, as they did with the PROBIT study, looking at BFHI. And Flowerman goes on to say that that there was no consistent association between intervention and beneficial outcomes. Well, she just completely discounted the fact that there was some evidence. She completely discounted that relationship with women of low education. She actually goes on to say that, well, because it was only beneficial for specific groups, maybe we should just use our clinical judgment and individualize. Well, this sounds a lot like discrimination. Should we really recommend a differential treatment for women with low education? I don't think so. It seems to me that really it's the system-level environmental changes that best support the elimination of the disparities that we see. In addition, she goes on and really focuses on this potential risk of either system-level interventions or exclusive breastfeeding. And she says that the avoidance of formula is actually controversial, and it's really hardly controversial. There's so much evidence supporting exclusive breastfeeding. She again brings up what Bass brought up with the pacifier issue and says that, again, that it confuses pacifiers and no protection against SIDS with pacifiers somehow being protective early on, and brings up the Cochrane review, which was a review looking at the evidence of pacifier interference with breastfeeding, but the Cochrane review really looked at outcomes after a few months of life. It didn't really look at outcomes after a couple of weeks, so it may be that women would have already weaned by the time these outcomes were appreciated. So pacifiers may, in fact, be problematic in early days. And fortunately, we actually have some more recent evidence. This is a paper that was just published in Breastfeeding Medicine by Laura Kara, looking at PRAMS data. PRAMS is the Pregnancy Risk Assessment Monitoring System. It's a survey that's given to women with babies that are between like 12 and 16 weeks of age. And the things that I've bolded here really support the fact that babies shouldn't be supplemented with formula, and that maybe using a pacifier is not such a great thing, because as I've bolded, there's a decrease in any breastfeeding, and the things that are starred, which supplementation and pacifier use is starred, there's an effect on exclusivity as well. And then Flowerman goes on to talk about this issue of non-exclusive breastfeeding as maybe somehow being protective, and she really points to her own studies. And this is really bothersome because this was an invited editorial to talk about the U.S. Preventive Services Task Force recommendations for methods to support breastfeeding, well, her papers weren't reviewed by the U.S. Preventive Services Task Force. You know, so she's sort of interjecting her randomized controlled trials, even though they really weren't among the body of evidence to say that those were best ways to protect continuation of breastfeeding. In addition, she goes on to say that exclusive breastfeeding may actually be harmful, and that things like hyperbilirubinemia and dehydration and readmission because of problems of not breastfeeding sufficiently would happen from exclusive breastfeeding. And really, each of these issues can be supported independently with good policies and good practice. And it's really not exclusive breastfeeding that contributes to hyperbilirubinemia. It's just lack of suckling and good breastfeeding care. So none of really what she's saying is supported by the evidence other than her own study, which is a study that looks at babies that lose more than 5% of their birth weight within the first 48 hours. She claims that those babies that are given a supplement, if they lose more than 5% of their birth weight, then increases their likelihood that they're going to continue to breastfeed later on. And she actually calls it exclusive, but in fact, you know, they're never exclusive because they've gotten that supplementation. So really, that early supplementation has more harm than good. So how do we measure the Baby-Friendly Hospital Initiative system-level outcomes? I think that we have a lot of work to do to figure out the best ways to actually capture the best data to support the recommendation to implement the BFHI. And is it really designation that captures the implementation the best? I mean, it may be that the process of designation is the best way to figure this out. Or maybe now with electronic health records, there's better ways to actually capture the true implementation of each of the 10 steps. So I'm going to end with some good news, and that is that we have provisionally been accepted to report our findings from the Best Fed Initiative, which is the CDC-funded NICU initiative where 89 hospitals in the U.S. implemented the BFHI. NICU is National Institute for Children's Health Quality. And in fact, we did show an increase, statistically significant increase in exclusive breastfeeding. Furthermore, we showed an increase in skin-to-skin contact, which again, skin-to-skin contact is an outcome of importance as well. It's not just breastfeeding, but skin-to-skin care is something that supports better health outcomes. And then from CHAMPS, I think one of the things that hasn't really been looked at sufficiently is the fact that there are great disparities. And it's not just women of low education, but really through the CHAMPS initiative, we've, for the first time, really begun to close the gap between exclusive breastfeeding initiation among Black African American women and other women in the hospitals that we're serving. So in conclusions, don't believe everything you read. Maybe we do need randomized controlled trials to show the benefits of the BFHR, but maybe we don't. Maybe we really do have sufficient evidence for each one of the steps on their own merit. And the BFHI is supported by the government, by many organizations, and it really may be the best way we can reduce breastfeeding disparities, and it really is the best way to support the establishment of exclusive breastfeeding. I'm going to end with a quote from another opinion piece. This time, it was written by one of the associate editors of JAMA Pediatrics, Dimitri Christakis, and this was published in December, so right after all these other editorials. Unfortunately, it didn't get very much press, but he goes on to say that there's a lot of directives coming from the United States Preventive Services Task Force, do this, do that. But really, what he says is we should be draining the sea of these advisory directives and selectively refilling it with things for which there is sound evidence and proven value. If we're to take this approach, we might well add breastfeeding support right after vaccinations. I have to agree with him. So I'm going to see if the team has any questions for me in the chat box. Thank you very much for attending today.
Thank you, Laurie. That was a really great presentation, and it will be on our CHAMPS website so people can get it. I know we're right at 1 o'clock Eastern Time right now. I think Laurie's prepared to stay on for a few more minutes if there's any questions, but we will have another webinar coming up from Laurie that we'll be advertising soon, which deals more with some of the sleep materials and other things. So Rebecca, do you want to add anything about if people want to contact Laurie or have questions about this and when we'll have this available on our website? Or Laura? Anyone from CHAMP?
If anyone has any questions, they can email the champsbreastfeed@gmail.com or visit our website, champsbreastfeed.org. And the slides are already on there, and then this recording will be on there later today.
Thank you.
Thanks, Rebecca.
Laurie, anything you want to address? I hear a lot of people are hanging on. I don't want to keep it going too long, but was there anything in the chat that you wanted to address, Laurie? Any questions?
Yeah, I don't see anything in the chat.
Okay.
Let's see. Yeah, no, I don't see anything in the chat. So hopefully,
okay. People were listening.
yeah, and hopefully,
okay, guys,
maybe the questions will come up, over the course of the day.
Thank you very much, Laurie. Then we will conclude it here at the hour mark, and thank you for all of you for tuning in. We had a huge audience, and let us know if you have any questions or comments, and look out for the next webinar that we're going to be doing on a similar theme. And of course, our Wednesday webinars are every month through about June from now. So we will have those also all advertised on our website. So take care, and thanks for tuning in. Bye-bye.
Have a great day. Thanks.